Calcium disorders are complicated. There's a lot you have to know in terms of identifying someone who has a calcium disorder and how to treat it, and then actually coming up with a diagnosis. The cool thing is that if you understand the system, how calcium actually is managed by the body, you can generally get the answer with only a few lab tests. So to open the lecture, I want to create that pathophysiology of calcium, how you attack someone who's hypercalcemic and hypocalcemic without knowing a diagnosis, and then the rest of the video will be dedicated to using laboratory values to come up with the right answer. That is, what is the etiology of this calcium disorder? Let's start off by talking a little bit about pathophysiology. In the parathyroid glands that are located behind the thyroid, you have cells that have packaged parathyroid hormone into vesicles, ready for launch. There is a calcium sensing receptor, which is inhibitory, such that if the calcium levels in the blood rise, the calcium turns on this receptor and turns off the release of PTH. If the calcium levels are low, the calcium sensing receptor is not activated and the release of parathyroid hormone is permitted by disinhibition. Parathyroid hormone is the primary way the body manages calcium. And parathyroid hormone enacts effects on 3 different organ systems. The bone, the kidney, and indirectly in the gut. And it is indirectly by means of the kidney. The kidney turns on 125 vitamin D. And it's the vitamin D that causes absorption of the gut. But creation of 125 vitamin D from 25 vitamin D is under direct control of parathyroid hormone. 1-alpha hydroxylase is stimulated by parathyroid hormone. So what does parathyroid hormone do at each of these places? In the bone, it's going to cause reabsorption of bone. Osteoblasts stimulate osteoclasts, clasts clear bone. It takes the bony matrix and releases the minerals. You're going to see an elevation in the calcium and an elevation in the phos, because after all, calcium and phos make up the bony matrix. In the kidney, parathyroid hormone is going to cause reabsorption of calcium and the excretion of phosphorus. In the gut, vitamin D, under direction of parathyroid hormone, is going to cause absorption of both calcium and phosphorus. Now, throughout this video, what I want you to remember is that if the kidney is working, the kidney always wins. That is to say, because in the kidney is the only place where phosphorus is decreased under the influence of parathyroid hormone, we can then use, if the kidney is working, the kidney always wins. That is, if there's too much parathyroid hormone, calcium will elevate and phos will fall. If there's too little parathyroid hormone, calcium will fall and phos will rise. That's a generalization. You'll see how it's not always true, but I want you to keep in mind the kidney always wins. There's one more piece to this, and that is artificial vitamin D. It's going to be 125 vitamin D that comes from granulomas, such as TB or sarcoid. Don't worry about the mechanism. Just know that this system can be deranged by problems with the kidney, which can lead to problems of making vitamin D, problems of parathyroid, either too much or too little, or by granulomatous disease that secretes 125 vitamin D. If you understand that, going through the etiologies is going to be simple. But as you approach real patients, I want you to also realize that most calcium is bound to albumin. Only about 1% is free ionized calcium. And so if you're worried about calcium, what you really want to assess is ionized calcium. But you can assess sort of poor man's version without actually getting an expensive test by comparing the amount of albumin to calcium. A normal albumin is 4. A normal calcium is 10. For every change in albumin of 1, the calcium changes in the opposite direction by 0.8. What I mean is, if the albumin is 3, the calcium will say 9.2. Because the albumin changed by 1, you add back the 0.8 to 9.2 to get 10. These numbers say the same thing. The calcium level is the same, but because most of the calcium is albumin bound, when you measure calcium, the measured value may not reflect the true ionized calcium circulating value. To ballpark it, you add back 0.8 calciums for every 1 albumin deficient. Of course, albumin generally doesn't get to be elevated. It is usually low when you consider this. The whole point of this is if low albumin and low calcium, calcium might correct into normal ranges. So first understand the pathophysiology. I want you to see this picture whenever we talk about any of the etiologies. Parathyroid hormone to bone, reabsorption. Parathyroid hormone into kidney, phosphorus excretion and creation of vitamin D. Vitamin D in the gut, calcium and phos absorption. Elevations in the calcium turn off parathyroid hormone release. Low levels of calcium in the blood activate parathyroid hormone. Granulomatous disease can cause fakely elevated vitamin D, and then a number of diseases can either increase or decrease the amount of parathyroid hormone. And so I want you to see that most of the diagnoses are going to be made with a parathyroid hormone, a calcium, and a phosphorus. Every once in a while, you'll need to check a vitamin D. Before we go into etiologies, let's talk about how you manage someone with calcium disturbances. Let's talk about hypocalcemia first because it's easier. Someone who has a low calcium is going to present with tetany, perioral tingling, Trousseau sign, and Chvostek sign. Trousseau sign is where you inflate the blood pressure cuff and you get a carpopedal spasm. You deflate the cuff, hand goes to normal. Chvostek sign is Chvos taps sign. If you keep tapping the facial nerve, there's no dulling of the reflex. All of these are symptoms of hypocalcemia. If you have these symptoms, check a calcium. But when you're dealing with hypocalcemia, that is, you see a low calcium on a lab you order, the first thing you do is check the albumin. Because remember, calcium might correct. If it corrects, awesome, you're done. It's not a deficiency of calcium, it's just a product of albumin. But if it's still low, if you have to check something, you want to check the ionized calcium. But if they have symptoms and they're hypocalcemic, you don't have to do this stuff, right? You know they're symptomatic, they've got hypocalcemia, and what they need is, if their ionized calcium is low, they're going to need calcium. The question is, how do you give that calcium? This isn't someone who's osteopenic. This isn't someone who's got vitamin D deficiency. This is someone who is overtly hypocalcemic with a decreased ionized calcium. You are going to give them IV calcium. Calcium gluconate or calcium carbonate, doesn't matter. You need to give it IV because the symptoms are there, and if you just let them go, they can have a seizure or arrhythmia. So the management of hypocalcemia is actually really easy. If low, give IV calcium. Done. The management of hypercalcemia is a little more difficult. So patients with hypercalcemia, if they have obvious symptoms, that is kidney stones, psychic moans, that is altered mental status, abdominal groans, and painful bones. Bone, stones, moans, and groans. Kidney stones, bone pain, altered mental status, and abdominal pain. If they've got a high calcium and they have this, treat it. It's real. We'll talk about the treatment in just a second. But if they don't have this, all you need to do is recheck the calcium. And only if on the recheck do they have an elevated calcium do you need to treat these people. If the recheck is normal, you can stop. The idea is that if someone has an elevated calcium on laboratories and that's it, just recheck it. If it really is indeed elevated, you can think about treating it or more likely diagnosing it. If the person comes in with hypercalcemia, has symptoms of hypercalcemia, you don't have time to mess around, you're just going to treat. So I want you to see this. If you cascade straight down, you're going more for the treatment side. If symptomatic, then treatment. If asymptomatic, then diagnose. And the diagnosis will be the rest of the video. So the question then is, how do we treat hypercalcemia that is symptomatic? There's been a major shift in the way we treat hypercalcemia. It used to be fluid and Lasix, furosemide, fluid and diuretics. Loop diuretics block paracellular reabsorption of calcium in the ascending loop of Henle, which led to a calciuria, which depleted calcium. Turns out people were using it wrong. If you give furosemide, a loop diuretic, early in resuscitation, what you do is dry the patient out and concentrate the calcium, making the symptoms worse. So there's a couple of ways you can treat hypercalcemia, but what I want you to hear is volume, 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 and some meds. The answer to treating hypercalcemia is to dilute it. Solution to pollution is dilution. Give hypercalcemia lots of fluids. So no matter what step you make, intravenous fluids is the right answer. But in addition to intravenous fluids, there's a couple of things you can do. And it's divided into 3 phases. There's the immediate phase. There's the long-term phase. And then there's this kind of indeterminate in-between phase, which is loop diuretics. but I'm kind of not making a big deal about this because this is sort of fallen off. What you're going to really be choosing from is calcitonin, calcitone down, intravenous, very rapid on, very rapid off. It's basically if the calcium's 18, they're bugging out, they're in pain, they're completely altered, you give them some calcitonin while you hit them with fluids. The long-term therapy has become now the standard, which are the bisphosphonates. It used to be very clear. Give calcitonin, then fluids, then a diuretic, and bisphosphonates are sort of floating around. They're kind of new. Now, the mainstay of therapy is early bisphosphonates and early intravenous fluid. You can use loop diuretics once they have been adequately volume resuscitated. That is, they are actually volume up, and you're giving the diuretic to actually get the fluid off, and as a bonus, some calcium goes with it. But that's how I want you to see diuresis. It's got to be because they're volume up. You give early bisphosphonates and early fluid, loop diuretics way down the line, and calcitonin, probably not going to be that useful. The vignette has to be screaming at you, super high calcium, super symptomatic, in order for this to be the right answer. Most of the time, the right answer for hypercalcemia is going to be fluids and bisphosphonates. So that actually cleaned up a lot of things and made it a lot easier. So what I want you to see is, if symptomatic, treat. For hypocalcemia, you give calcium. For symptomatic hypercalcemia, you give fluids and bisphosphonates. If they're not symptomatic and they have an abnormal in their electrolytes, what you should look for is either a bogus lab or albumin correcting to normal. And only if they have a persistent low value that does not correct, and it's real, but it's asymptomatic, do you then go on to try to find a diagnosis. And this is where we're going to next in the discussion of calcium. Let's start talking about some of the diseases that you're going to see calcium disorders with. Let's start off with hypercalcemia and go through the list. The first, and by far the most common, is hyperparathyroidism. It comes in three different categories: primary, secondary, and tertiary. Primary is autonomous secretion, but it's usually a single gland. It is an autonomous adenoma, generally non-cancerous. Tertiary, also autonomous, but it will have been because of constant stimulation, so you'll see multiple adenomas. You'll see how all of this plays in just a minute. Secondary hyperparathyroidism is a product of early renal failure and is actually an appropriate response to relative hypocalcemia. Patients who have hyperparathyroidism are going to present with, of course, hypercalcemia. But because parathyroid hormone goes to the bone and starts turning over the bone, the patients may present with hypercalcemia and pathologic fractures because of decreased bone density, or unique to hyperparathyroidism, the brown tumors. They're not really malignancies, they literally eat away the bone. The diagnosis is going to be made by an elevated parathyroid hormone. And remember now, bring out that list in the very beginning. If you have elevations in the parathyroid hormone, and it is an inappropriate elevation of parathyroid hormone, the kidney wins. The kidney wins, so the calcium goes up and the phos goes down. What should happen to that calcium sensing receptor is that there's a lot of calcium here, so it should turn off. But it's making parathyroid hormone anyway, without listening to the amount of calcium in the blood. And so elevations in parathyroid hormone will cause elevations in the calcium. And even though calcium is there to turn off the calcium sensing receptor, parathyroid hormone is still made, kidney's working, the kidney wins, so the phosphorus is low. You do not need a vitamin D to diagnose hyperparathyroidism. Hyperparathyroidism is an elevated potassium, elevated calcium, and a low phos. Why is that? Because there is an autonomous production of parathyroid hormone by the parathyroid gland that leads to an elevated calcium. And instead of turning off, more parathyroid hormone is made anyway. Here's how you differentiate primary, secondary, and tertiary. You get a sestamibi scan. Remember, you've got 4 parathyroid glands. If you had primary hyperparathyroidism, you would have 1 gland with an adenoma. It's making PTH regardless of what the calcium level is. But because the calcium is elevated, where there's not an autonomous adenoma, the secretion of parathyroid hormone is very much suppressed. So the other parathyroid glands are atrophied. This is primary. Compare that to the parathyroid glands of tertiary hyperparathyroidism, where what has happened is chronically low calciums because of the inability to make vitamin D has led to an upregulation of parathyroid hormone appropriately. But long-term, constant stimulation of parathyroid hormone leads to tertiary hyperparathyroidism, where you have multiple areas that secrete parathyroid hormone because they're so used to doing it. So the sestamibi scan that shows you a single adenoma with multiple small atrophied parathyroid glands, primary. If you look at a sestamibi scan and see a whole bunch of lots of big adenomas, that's tertiary. The treatment is the same. The treatment is going to be resection. And when you resect parathyroid glands, you have to watch out for hypocalcemia. Why? Because these glands are atrophied, and when you remove the big adenoma that made all the parathyroid hormone, these guys might need a little time to come back online. Now, this is more in chronic kidney disease management, but the reason why we give people drugs like cinacalcet, which is a calcium mimetic agent, is to prevent tertiary hyperparathyroidism by reducing the amount of parathyroid hormone made. Don't worry so much about this. Pay attention in this lecture to the difference between primary and tertiary, and recognizing that hyperparathyroidism is going to be made on a diagnosis with an increase in parathyroid hormone, an increased calcium, and a decreased phos. You don't need vitamin D. Let's compare this now to hypercalcemia associated with malignancy. There's 2 ways you can get there. Cancer can either produce METs or have a paraneoplastic syndrome, where they secrete parathyroid hormone related peptide. This is going to be squamous cell carcinoma of the lung. When cancer is metastasized, it invades bone. and that causes a release of calcium and phosphorus. Now remember, the calcium sensing receptor in this case works. There's no autonomous secretion of parathyroid hormone. As the calcium levels rise from release of bony matrix from tumor invasion, the calcium level goes up, the calcium sensing receptor is activated, and it inhibits parathyroid hormone release. So what will the parathyroid hormone level be? Low. Because the parathyroid hormone level is low, the kidney can't win. It has no stimulus. It has no parathyroid hormone, so phosphorus will not be excreted. In the case of hypercalcemia secondary to cancer, you're going to look at an elevated calcium, an elevated phos, and a low PTH. This is from tumor invasion. If it is from parathyroid hormone-related peptide, it essentially is parathyroid hormone. Because the kidney is working and there's parathyroid hormone, the kidney wins. So the findings of hypercalcemia from a paraneoplastic syndrome is going to be an elevated calcium and a low phos. But the natural parathyroid glands are working. The high calcium turns off production of parathyroid hormone. So parathyroid hormone will be low. If you see high calcium, low phos, low parathyroid hormone, especially if they give you information about a chest mass, the answer to diagnose this is to obtain a parathyroid hormone-related peptide, which will be elevated. This is important because our test that assesses for parathyroid hormone does not assess parathyroid hormone-related peptide. So what's driving hypercalcemia and paraneoplastic syndrome is PTH, but the PTH is low. So the calcium is elevated because of PTH. In cancer from metastasis, the calcium is elevated from the metastasis, and therefore the parathyroid hormone is low. The difference between them is the phosphorus. And again, no vitamin D needed. I keep saying that, no vitamin D needed, no vitamin D needed. So when is vitamin D needed? Vitamin D is needed when you have hypervitaminosis D. One way you could get this is someone's just eaten a bunch of vitamin D. Right? They're over-ingesting vitamin D. Not the way you're going to see that on the vignette. So eliminate that. We spoke about it already in the very beginning of the lecture. In the case of granulomatous disease, excess completed vitamin D is made. If you have a lot of vitamin D, you are going to absorb calcium and phosphorus from the gut. Because the parathyroid glands are working, calcium is going to inhibit the release of parathyroid hormone. That looks a lot like cancer mets. But in the vignette, you're going to have a history of sarcoid, of TB, of some granuloma. If you need to tell the difference between a granulomatous disease and metastasis, you do obtain a 125 vitamin D. This is the time where 125 vitamin D is going to be the right answer, is when you're trying to say this pattern of calcium, phos, and parathyroid hormone is a product of hypervitaminosis D secondary to granulomatous disease. Okay. One last tidbit, and this is sort of small, and so we're going to go through them briefly. There's a hypercalcemia of immobilization. Guess what happens in the vignette on that one? Calcium is elevated because there is immobility. The calcium is elevated, so the PTH is low. Because the PTH is low, the kidney doesn't win, the phos is elevated. You're not going to see this in a vignette. You're not going to see this in real life unless maybe you're an orthopedist who has someone with a really bad fracture. But if you see old person or trauma, immobility, high calcium, asymptomatic, hypercalcemia, immobility. Rare. The other thing that's rare is familial or in hypercalcemia, hypercalcemic hypocalciuria. They have an asymptomatic elevation in their calcium, generally pretty benign, like in the 11 to 12 range. And if you check their urine calcium, it will be low. I'm brushing by these because these are more in the 280 range. And there's a lot of information in this lecture already. If you understand hyperparathyroidism and the hypercalcemia of cancer, you're doing great. Bonus points if you can identify the familial hypercalcemic hypocalciuria that presents with an asymptomatic elevation in their calcium. And because they need to have a higher set point, is really what happens. They have a high set point. The parathyroid hormone might be slightly elevated. So I want you to also feel the derangements. Significant derangements in calcium, phos, and parathyroid hormone for hyperparathyroidism and hypercalcemia of cancer. Less derangements in hypercalcemia, immobility, and familial hypercalcemic hypocalciuria. Granulomatous disease, cancer, and adenomas cause big number swings and symptoms. These guys cause very little. So I want you to see that most of the answers obtained are gotten with a parathyroid hormone, calcium, and phosphorus. Every once in a while, granulomatous disease, get a vitamin D. Every once in a while, family history listed in the question, get a urine calcium. That's most of the calcium disorders. Hypocalcemia, just like in terms of the management, working up the differential, not that challenging either. By far, what you're going to see the most on the surgical ward and on the surgical shelf is the cause of hypocalcemia being an oopsie and during a thyroidectomy or during an appropriate response of a parathyroid resection. So what you're going to look for is hypoparathyroidism. And hypoparathyroidism is generally going to be iatrogenic. It can be autoimmune, but very rarely. And so either this is going to happen during a thyroid surgery where they accidentally take out the parathyroids, or during a parathyroid resection for an adenoma, and you haven't had time for those other glands to turn on. So what you're going to see is someone present with the symptoms we talked about earlier, tetany and perioral tingling. This happens post-op day 1. The diagnosis is made by a low parathyroid hormone, which is driving a low calcium. Because the parathyroid hormone isn't there, there's nothing to reabsorb the phosphorus nor excrete it. Phosphorus is generally irrelevant. The treatment is going to be calcium. Remember, IV calcium. It'll come back online if it's just giving time, or you'll need to supplement parathyroid hormone in the future. You will not have to diagnose this from the labs. You'll get it from the history alone. If you have a question about a thyroidectomy or a parathyroid resection and they are hypocalcemic, iatrogenic, give them calcium. But hypoparathyroidism can occur in other situations where the PTH is low, therefore the calcium is low. There is a terribly named disease called pseudo-hypoparathyroidism. And in pseudo-hypoparathyroidism, there is actually end organ resistance to parathyroid hormone insensitivity. It is as though you have a low parathyroid hormone, even though the parathyroid hormone levels will be elevated. This is hypocalcemia, and so you're going to have decreased levels of calcium And because you don't have a lot of phosphorus, because you don't have a lot of parathyroid hormone, low levels of phosphorus. Just be able to identify it. Elevated parathyroid hormone levels, but low calcium. If you see this combination, it's pseudo-hypoparathyroidism. Terribly named disease. It just means parathyroid hormone insensitivity. Where it becomes a bigger deal, and where you're going to see a lot of test questions go in terms of calcium management, is in vitamin D deficiency. Vitamin D comes from dairy products and sunshine. Patients with vitamin D deficiency are not going to be so deranged as the person who just had their parathyroid adenoma removed. Instead, what you're going to see is someone who's got osteopenia. They might have had a DEXA scan with a score of -2.0. The person who's at risk is someone who spends all day inside or doesn't eat enough dairy products. The way you diagnose vitamin D deficiency is not by getting parathyroid hormonal calcium at all. What you do is you get a vitamin D level, but it's a 25 vitamin D level, not a 125. And if they are vitamin D deficient, that is the vitamin D level is less than 30, you're going to treat them with calcium and vitamin D. You will start them off with high dose PO vitamin D. High dose PO vitamin D. And so if you look at your vignette and their option choices show you IV calcium, calcium and vitamin D, or high dose vitamin D, what they're trying to get you to look at is the cause of hypocalcemia. If their hypocalcemia is severe, pick IV calcium. If the degree of their hypocalcemia is not that bad and they've just got a little bit of osteopenia, then you're going to choose vitamin D replacement therapy. But if, and this is getting more into endocrine, but if they are significantly osteopenic, here come the bisphosphonates again. Bisphosphonates are the therapy of choice. So the treatments are kind of all over the place and you can't make a really good grid. But what you want to see is not severe disease, PO replacement. Severe disease, IV replacement. Bisphosphonate therapy is used for significant osteopenia, generally secondary to vitamin D deficiency, so you treat them both. And bisphosphonates can be used in hypercalcemia, especially when it's very, very elevated and they are symptomatic. We're going to finish up with two slightly lower yield diseases. One is going to be chronic kidney disease, and the other is pancreatitis. Because it might come up that, hey, this person has an acute hypocalcemia, and the reason is sequestration. It is one of the Ranson criteria that if their calcium drops in pancreatitis, it's an ominous sign. Just be aware that that exists. It's not really a calcium disorder, it's a disorder of inflammation. And in chronic kidney disease, when the creatinine isn't that bad, in early chronic kidney disease, what happens is impairment of vitamin D formation. This leads to the secondary hyperparathyroidism. Vitamin D can't absorb the calcium. It's like you're vitamin D deficient. These patients are definitely the ones you treat with calcium and vitamin D. The bonus points here is going to be the cinacalcet, the calcimimetic agent that tries to decrease the amount of parathyroid hormone while you replace your calcium and vitamin D. If someone is late stage, their issues are going to be more with hyperphosphatemia, not so much hypocalcemia. So what I want you to see is that if you're talking about hypocalcemia, early CKD, vitamin D impairment, secondary hyperparathyroidism, and don't forget about pancreatitis. So there was a lot in this lecture too, and it isn't very fluid because everything is its own disease and kind of own disease severity. You're going to get a lot of questions about how do you manage symptomatic hypercalcemia, fluid, bisphosphonates, and then maybe calcitonin, maybe some diuretics. You are going to get a question about iatrogenic hypoparathyroidism. What do you do? IV calcium. The question is also going to ask you, how much calcium do you give and by which route? Calcium and vitamin D, high dose vitamin D. So pay attention to the severity of the disease. The more deranged the labs, the more severe the disease. The more likely you are to use IV therapy. The less deranged the labs, the more towards normal they are. The less severe the disease, the more likely PO you're going to use. And then be able to identify the different causes of hypercalcemia, knowing when to get that 125 vitamin D and when to get that 25 vitamin D. Punchline is 25 vitamin D and vitamin D deficiency, 125 vitamin D in granulomatous disease. That's hypercalcemia.